So today's topic is salivary gland tumors. So before starting with salivary gland tumors, we must understand there's some basic rules of ETs, which is which is mostly seen, which will be seen in uh, the chapter or the lesions. First of all, 80% of the carotid tumors, they are benign. Second, and the 80% of these carotid tumors, they are pleomorphic adenomas. 80% of the salivary gland pleomorphic adenomas, they occur in the carotid, means they are more common in carotid gland than in submandibular or in sublingual gland. 80% of the parotid pleomorphic adenomas, they occur in the superficial lobe of the parotid gland. And last, 80% of untreated pleomorphic adenomas, they remain mostly benign. Okay. So, what is the etiology behind? This is what we are talking in general regarding salivary gland tumors. So, etiology which is very commonly seen is, first is viruses. The viruses which are mostly involved or implicated are EBV, which is commonly called as Epstein-Barr virus, CMV or cytomegalovirus, and polyomavirus. These, they are considered to be responsible for salivary gland tumors. Second is ionizing radiation. Third is the increased risk, occupational risk. The persons or the people which are working in asbestos, nickel compounds, or in silica dust factories, it is seen that the salivary gland tumors, they are mostly common in this population. They are also seen in the woodworking, rubber industries, and beauty salons. The persons or the male or females which are mostly seen in which are working in these areas, they also suffer from salivary gland tumors. One very interesting etiological factor is the lifestyle, which is related to lifestyle. It has been seen that the Watson's tumors, it showed a very strong association with cigarette smoking. Then lastly, there are endogenous hormones which are also implicated. Histogenesis, it is the cell of origin for a neoplasm rather than the developmental process underlying the tumor. It is by this we mean it is not the tumor has not occurred because of some developmental defects or the developmental processes. Rather, it is originated from the cell of origin. Second is the formation or development of tissue from the undifferentiated cells of the germ layers of the embryo. So these are the more commonly histogenesis for salivary gland tumors. Hello. हेलो देख लो तुम्हारे हिसाब से कैसे तुम्हारा है, अब इसमें मैं नहीं बोल सकता, तो एक बार देख लो, कर लेना, नहीं तो करा लो यार, याद कर लो, है ना। तो काट लो। प्रिया तुम एक बार बात कर, मेरी बात सुनो, तुम मुझसे बात कर ले, बात कोशिश करें, देखो बताइए, है ना, बात कर लेते हैं। Now we have this taxonomic classification for salivary gland tumors. In this, we have classification of neoplasm, that is whether the neoplasm is composed of luminal and modified myoepithelial cells, or the neoplasm which is composed primarily of myoepithelial cells or basal cells. Then there is neoplasm which is composed primarily of luminal or sinus cells, and neoplasm which is composed of undifferentiated cells. Then we have subclassification of neoplasms, which is histologically with apparent proteoglycan and basal lamina production, histologically lacking obvious proteoglycan and basal lamina production. Then we have benign neoplasm, such as pleomorphic adenomas, basal cell adenomas, cellular pleomorphic adenoma, Watson's tumor. Then we have myopithelioma, canalicular adenoma, ductal papillomas, cyst adenoma, or oncocytoma. Then we have malignant neoplasms, such as malignant mixed tumor, which is also called as carcinoma ex pleomorphic adenoma. Then we have adenomocystic carcinoma, cribriform pattern. Then we have basal cell adenocarcinoma. Then we have adenocystic carcinoma, solid and tubular. Then we have epithelial myopithelial carcinoma. Then we have mucoepidermoid carcinoma. Then we have PLG, which is more commonly known as polymorphous low-grade adenocarcinoma. Then we have myoepithelial carcinoma. Then we have actinic carcinoma, salivary gland carcinoma, adenocarcinoma, oncocytic carcinoma. Then we have undifferentiated carcinoma or small cell carcinoma, which is totally composed of undifferentiated cells. Now we'll start with the first benign tumor, that is pleomorphic adenoma, which is also called as mixed tumor. The name was suggested by Willis. It is the most common neoplasm of the salivary gland. It is a benign tumor neoplasm. It is composed of cells which have the ability to differentiate into epithelial component, that is ductal and non-ductal cells, and mesenchymal, showing chondroid, myxoid, or osseous cells. Pleomorphic adenoma is also known as branchioma. It is also known as enclavoma. It is also called as teratoma. It is also called as cylindroma. It is also called as myxochondrocarcinoma. And the origin is from the epithelial part. Now there is a genetic part attached to it. It shows cytogenetic abnormalities in chromosome 12q13.15. Then we have putative pleomorphic adenoma gene, that is called as PLAG1, has been mapped to chromosome 8q12. Clinical features: it is the most common tumor of salivary glands. Mostly it is seen in parotid glands, around 60 to 70%. 40 to 60% is seen in submandibular glands. 40 to 70% is seen in minor salivary glands. It is very seldomly seen in sublingual glands. It is more common during the age of 30 to 50 years, more common in females, and the ratio is 3:1 to 4:1 in males. In parotid, it is mostly seen in the lower lobe of the superior lobe as a mass over the angle of the mandible, below and in front of the ear. Clinical presentation, since it is a benign tumor, it will be painless, it will be slow growing, firm mass, initially small in size and begins to increase in size, but it will be very slow. Initially movable, but with continued growth, it becomes more nodular and becomes less movable. Recurrent tumor will be multinodular and it will be fixed on palpation. Palate is considered to be the most common site, and it is seldomly ulcerated until unless it is secondarily traumatized. As you can see in this slide, a firm mass which is seen on the lateral side of the midline of the palate. And the second photograph, you can see the tumor of the pterygomandibular area, pleomorphic adenoma. Most common investigations done are MRI, magnetic resonance imaging, and CT scans. Now coming to the most important part for us, the microscopic features. Hallmark is morphologic diversity, as it is showing the epithelial as well as mesenchymal component. It demonstrates glandular epithelium and mesenchyme-like tissues, and the proportion of each component varies widely. It is a very well circumscribed and encapsulated tumor. The epithelium is usually seen in the form of ducts and cystic structures. It may also occur as islands or sheets of cells, anastomosing cords, and foci of keratinizing squamous cells and spindle cells. Foot and Frazel in the year 1954 categorized pleomorphic adenoma into 4 types. First is primarily myxoid, which is approximately 36%. Then we have myxoid and cellular component in equal proportions, that is 30%. Cellular, predominantly cellular, rather 22%, and 12% is extremely cellular. Now the myoepithelial cells, they are the major component of pleomorphic adenomas and have variable morphologies. Sometimes they are seen as angular spindle, some with eccentric nucleus and resembling plasma cells. They are also responsible for characteristic mesenchyme-like changes. Vacuolar degeneration of these myoepithelial cells, they give a chondroid appearance. And the stroma exhibits areas of eosinophilic hyalinized change. Fat or osteoid is also seen. As you can see in this diagram, the chondroid area is seen. You can see that the outermost layer, that is the connective tissue capsule. Then we have ductal myoepithelial cells proliferating as sheets and strands. Tubular structures with eosinophilic coagulum. Then we have myxoid area, and then we have osseous area. So you can see it is therefore It is called as mixed tumor. As you can see, the upper photograph which is showing the mixed tumor, which is prominently showing the cartilaginous differentiation. And you can see the surrounding ducts are there and myoepithelial cells. In the second photograph, you can see the plasma sarcoid type of myoepithelial cells. In this slide, you can see the upper photograph showing the ductal structures and a myxomatous background. In the second photograph, you can see the chondroid material on the right side and with the adjacent ductal epithelium and myoepithelial cells. In this photograph, the upper one showing the cellular mixed tumor, because it is highly cellular, and this can be mistaken for a malignant tumor. In the second or the lower one, you can see the pleomorphic adenoma showing bone forming but osseous metaplasia in stroma. Now coming to the treatment and prognosis part, surgical excision is the treatment of choice. Superficial carotidectomy with preservation of the facial nerve. In this, the local enucleation is to be avoided, which can result in the seeding of the tumor bed. If the deep lobe of the carotid gland is affected, the total carotidectomy is usually necessary with the preservation of the facial nerve. In case of submandibular tumors, if at all pleomorphic adenoma occurs in submandibular tumors, it is the total removal of the gland with the tumor is preferred. The malignant counterpart of pleomorphic adenoma is called as carcinoma ex pleomorphic adenoma, which is a potential complication for pleomorphic adenomas. The risk of malignant transformation is not that high, it is approximately 5% of all the cases. Now coming to the myoepithelium, it was a term which was coined by Sheldon in 1943. It is not a very common tumor, less than 1% of all the salivary gland tumors. Now it usually represents the one-sided variant of the or the opposite end of the pleomorphic adenoma. As the pleomorphic adenoma was showing that mixed pattern, the myoepithelium is composed entirely of myoepithelial cells. Clinical features: it is mostly seen in adults. Males and females are equally affected. Site parotid is the most common, and palate is the most common intraorally. It is also a slow enlarging and asymptomatic mass since it is a benign tumor. Mass is usually 1 to 5 centimeter in diameter. Histologic features: it is well encapsulated tumor. It is composed exclusively or almost of neoplastic epithelial cells only. These neoplastic cells, they are arranged in sheets, nests, interconnecting trabeculae, ribbon shape, giving solid, myxoid, reticular, microcystic, and cubiform growth patterns. The component cells may be spindle shaped, they may be plasmacytoid, they may be clear, polygonal, epithelioid, baseloid, or oncocytic in type. You can see the first photograph on your left side. It is showing the typical plasmacytoid pattern, showing eccentric nuclei and abundant of eosinophilic cytoplasm. On the right side, or rather the B, which is the photograph which is designated as B, showing the spindle cell pattern, showing the uniform population of interlacing bundles of spindle cells with moderate amounts of light eosinophilic cytoplasm. The differential diagnosis: myoepithelial carcinomas, pleomorphic adenomas, nodular fasciitis, solitary fibrous tumor, fibrous histiocytoma, leiomyoma, and schwannoma. The treatment of myoepithelioma: complete excision with a rim of normal surrounding tissue. Then, coming on to the next benign salivary gland tumor, that is called as oncocytoma. It is also called as oncocytic adenoma, or oxyphilic adenoma, or acidophilic adenoma. It is a benign tumor which is composed of epithelial cells, large epithelial cells rather, which are called as oncocytes. These oncocytes, they have granular eosinophilic cytoplasm and a large number of atypical mitochondria. This granularity is because of mitochondria. It is a rare neoplasm, representing approximately 1% of all the salivary gland tumors. Apart from salivary gland, oncocytes, they are also seen in thyroid, parathyroid, as well as in the kidney. Clinical features: it is predominantly a tumor of oral adults, mostly seen in 50 to 80 years of age. A slight predilection for females is seen. The site is the major salivary glands, and in salivary gland tumor and in salivary glands, parotid gland, approximately 85 to 90% of the cases are seen in parotid gland. The oncocytomas occurring in minor salivary glands, they are rare. Very rarely they are seen in minor salivary glands. Now coming to the clinical presentation, the tumors, since it is a benign tumor, again it will be a slow growing painless mass. It rarely exceeds 4 cm in diameter. Parotid oncocytomas, they are mostly seen in the superficial lobe, and bilateral tumors, they are also seen, occurring on both the sides, right as well as on the left side of the parotid gland. You can see the gross appearance of the oncocytoma. It is well circumscribed, solid angles, light brown in color. Histopathologic features: it is well circumscribed tumor, which is composed of sheets of large polyhedral cells, which are called as oncocytes, with abundant granular eosinophilic cytoplasm. This granularity is because of large number of atypical mitochondria. These cells are arranged in sheets, nests, or cords, which will give an alveolar or a glandular pattern. The cells have centrally located nuclei that can vary from small and hyperchromatic to large and vesicular. Little stroma is seen, usually in the form of thin fibrovascular septa. Lymphocytic infiltrate is also seen in such tumors. The granularity of cells is created by the overabundance of mitochondria. Now, these granules, they can be identified on a light microscope examination with a tungstic acid hematoxylin stain, which is more commonly known as PTAH stain. Now the cells they can also contain glycogen and can be very well stained with periodic acid shift stain technique. There are varied number of cells with clear cytoplasm, which is called as clear cell oncocytoma. As you can see in this slide, on the left side you can see a sheets of oncocytic cells with uniform, predominantly centrally located nuclei and abundant eosinophilic cytoplasm. The differential diagnosis for oncocytomas include the mucoepidermal carcinoma, pleomorphic adenoma, epithelial myopathic carcinoma, myopithelioma, basal cell adenoma, and acidic cell carcinoma. The treatment and prognosis. It is more common. The treatment is the surgical excision is the treatment of choice. After the removal of the tumor, the prognosis is good with a very low rate of recurrence. And the oncocytomas of the sinonasal glands, they can be locally aggressive and have been considered to be low-grade malignancies. Now, coming to the next benign tumor, which is called as Warthin's tumor. It is also called as papillary cyst adenoma lymphomatosum or adenolymphoma. It is the second most common tumor of the salivary glands. It was first recognized by Albrecht in the year 1910 and was quoted by Alice and Auclair in the year 1991, and it was described by Warthin in the year 1929. It occurs exclusively in the carotid gland. Histogenesis. The most accepted theory for this is the tumor arises in the salivary gland tissue anchored within the paraparotid or intraparotid lymph nodes during the embryogenesis. According to the Allegra, it is the most likely delayed hypersensitivity disease. Lymphocytes being an immune reaction to the salivary ducts which undergo oncocytic change. According to the Su and co-workers, lymphoid component of the tumor is an exaggerative secretory immune response. So these are the most common theories which are related to it. Studies have found certain cytogenetic abnormalities in the epithelial component. It is 8 times more commonly seen in smokers than in non-smokers. Epstein-Barr virus is also believed it has been implicated in the pathogenesis of the Warthin's tumor. Coming to the clinical features, it appears as a slow-growing, painless nodular mass of carotid gland. Since it is a benign tumor, it will grow slowly, and it will be painless. This form of fluctuant to on percussion. More commonly occurs in the tail of the parotid near the angle of the mandible. 15 to 14% of the cases they occur bilaterally. If they are occurring bilaterally, but they are metachronous, that means they are not occurring at the same time, but they are occurring at some different times. Very rarely it affects the submandibular gland or the minor slug glands. The lymphoid component is often less pronounced in these extraparotid sites. Whenever these extraparotid sites are involved, lymphoid component is less pronounced. It is more commonly in 60 to 80 years of age, more common in whites than in blacks. Male in more common in males than in females. It has been associated with cigarette smoking. Now, this association with smoking, it helps to explain the frequent bilaterality of the tumor, because any tumorigenic effects of smoking might be manifested in both the carotid. Therefore, they have said it is associated with smoking, because this Watson's tumor occurs in smokers, that too bilaterally. You can see the gross appearance of the Watson's tumor, presence of multiple large spaces, and which is the characteristic of this lesion. Histopath features. The tumors is composed of mixture of ductal epithelium and lymphoid stroma. It exhibits cyst formation with projection into the cystic space and a lymphoid stroma showing germinal centers. It is arranged in 2 layers. The inner luminal layer consists of tall columnar cells. Finally, granular eosinophilic cytoplasm with centrally placed palisaded and slightly hyperchromatic nuclei. The outer layers of the cells are oncocytic, triangular, and very occasionally they are fusiform basilar cells. Focal areas of squamous metaplasia or mucous cell prosoplastia is also seen. Eosinophilic coagulum present within this cystic spaces. The lymphoid stroma shows the germinal cell formation. As you can see in this diagram, you can see the lymphoid aggregates in the connective stroma. Then we have papillary projections, which is lined by double layered epithelium. Then we have cystic space containing eosinophilic coagulum. And then we have peripheral cells with palisading nuclei. As you can see in this photo or the histopath feature or histopath photograph, the Watson's tumor, which is showing the papillary cystic tumor with the dense lymphoid stroma. A closer look, you can see the lower one. The papillae and the glands are typically lined by columnar oncocytic luminal cells, in which the nuclei are often polarized towards the lumen. Beneath the luminal cells is a layer of basal cells, which are sharply demarcated from the underlying lymphoid stroma. Differential diagnosis. Oncocytic papillary cyst adenoma. Lymphoepithelial cystic lesions such as simple benign lymphoepithelial cyst. Then we have AIDS-related parotid cyst, lymphoepithelial sialidosis. Then we have mucosa-associated lymphoid tissues. Treatment and prognosis. The surgical removal is the treatment of choice. Then we have local resection of the tumor with minimum surrounding tissues removed. Superficial parotidectomy to avoid violating the tumor capsule. The recurrence rate is 6 to 12%. Then there is a malignant counterpart to it, which is called as carcinoma X papillary cyst adenoma lymphomatosum. But it is rare, which is a rarity. Then the next benign tumor is called as basal cell adenoma. Now, this basal cell adenoma is a neoplasm which is composed of uniform population of basilar epithelial cells, which is arranged in solid trabecular, tubular, or in membranous pattern. It was first reported back in Sasser and Klein in the year 1967. The histologic source is the intercarotid duct or the reserve cells. Then the monomorphic adenomas, the term is to be avoided because the ultrastructural and immunohistochemical studies they have shown that the basal cell adenomas are not necessarily composed of only one cell. Hello. Sure. Clinical features, it is mostly common in middle-aged, approximate age is around 57 years, more common in females than in males. The ratio is around 2:1. Most commonly involved gland is parotid gland, that to superficial lobe, and intraorally it is the upper lip and the buccal mucosa. The clinical presentation, it is a slow growing, freely movable mass, which is less than 3 centimeter in size. It is firm in consistency, which is cystic or and it is compressible also. One subtype is also noted, which is called as membranous basal cell adenoma, which appears to be hereditary in nature. When it occurs in combination with skin appendage tumors such as dermal cylindromas and trichoepitheliomas. Then we have multiple bilateral tumors. Because these tumors they often bear a histological resemblance to skin tumors, they are also called dermal analog tumors. There is the gross pathology, round to ovoid, well circumscribed, with smooth surface capsule, firm, and is similar to the lymph node. The membranous basal cell adenoma is mostly multinodular. Cut surface, homogeneous, solid appearance that may be interrupted by cysts of varying sizes, filled with brown or red mucinous or blood, gray white to pink red or brown in color. Histological features, the basal cells, they are uniform and regular. Two morphological forms are seen of these cells. First is the small cells with scanty cytoplasm and round deeply basophilic nucleus. Then we have a large cells which are amphiphilic to eosinophilic cytoplasm, overt pale staining nuclei. The larger pale cells they usually predominates with the smaller or the darker cells located in the peripheral portion of the epithelial tumor nest, course or ileus. Four morphological patterns are usually seen. Solid, then we have trabecular, tubular, and membranous type. Two consistent features are seen. There is a sharp demarcation between the neoplastic epithelial cells and the surrounding connective tissue. Then we have palisading of the peripheral cuboidal or slightly columnar cells that accentuates epithelial connective tissue interface. Now coming to the first solid type, We have large sheets and broad bands of basilar cells demonstrating palisading pattern. Cells demarcated from the connective stroma by a basement membrane. Then the inner portion, epithelial cells parallel to the basal cells tends to produce scattered, which are called as whorled eddies. Eddies they mature into squamous cells. They produce keratin to give the appearance of keratin pearl. The details of the squamous differentiation is frequently found in the solid variant of the tumor. This you can see the tabular type, narrow epithelial cells, islands forming an interconnecting cord-like architecture, which is called as reticular pattern. Then we have the tubular type, showing two cells, the inner cuboidal ductal cells and the outer layer of basilar cells. There is prominent multiple duct-like structures and with interluminal eosinophilic secretion. It occurs in conjugation with trabecular pattern to form a trabeculotubular pattern and is the least common of all variants. Then we have membranous type, presence of thick haline basement membrane-like material surrounds large globules. This is also seen within the epithelial nest forming coalescing or hyaline droplets. Epithelial islands they produce a jigsaw puzzle pattern. And haline material is usually a fast chain cluster. Differential diagnosis: mixed tumors, adenoid cystic carcinoma, cutaneous basal cell carcinoma, and basal cell adenocarcinoma. The treatment is similar to that of pleomorphic adenoma. The complete surgical removal is preferred. Recurrence is rare. The membranous subtype has 25 to 37% of the recurrence rate. The malignant counterpart is basal cell adenocarcinoma. Then, coming on to the next benign tumor, that is called as oncocytosis or nodular oncocytic hyperplasia. Shows the transformation of ductal and acinar cells to oncocytes. It is uncommon before the age of 50. The oncocytes, which is a common finding in the salivary glands. Oncocytosis usually refers to both the proliferation and accumulation of oncocytes within the salivary gland tissue. It may mimic a tumor both clinically and microscopically. Considered to be a metaplastic process rather than a neoplastic one. Clinical features: site parotid gland is the most common site, but in rare instances it may also involve the submandibular or minor salivary glands. It may be extensive enough to produce a large clinical swelling. Proliferation is multifocal and nodular. Sometimes entire gland can be replaced by oncocytes, which is diffuse hyperplastic oncocytosis. Oncocytosis occurs most commonly in older adults. Coming to the histopath features, it shows the focal nodular collection of oncocytes within the salivary gland tissue. The cells or the enlarged cells are polyhedral and they also demonstrate abundant granular eosinophilic cytoplasm due to the result of the proliferation of the mitochondria. These cells may have a clear cytoplasm from the accumulation of glycogen. The multifocal nature of the proliferation may be confused with that of metastatic tumor, especially when the oncocytes are clear in appearance. As you can see in this, the oncocytosis showing multifocal collection of clear oncocytes, which is usually marked by an arrow in the carotid gland. Coming to the treatment and prognosis part, oncocytosis is a benign condition and is often discovered only as an incidental finding. No further treatment is necessary and the prognosis is considered to be good or excellent.